You can have various types of pain and various locations of pain that could arise from your spine. But just because a person has symptoms, that doesn't mean it's only from the spine. So part of my job is to make sure we're thinking not outside the box, but not thinking with blinders on and say everything is because of the spine. If a person gets better from physical therapy, as an example, it doesn't really matter which nerve it was, because if they're better, you're not going to do anything aggressive about it anyway. As we progress through treatment, those people that don't respond to the earlier treatment, we tend to get more and more specific about the problem and specific about the treatment. When patients present with a spine problem, I assess them and sort of break it down into two categories. The first category is, are they experiencing radiating pain, say arm pain or leg pain? And the second group is back pain or neck pain. It tends to be the case that younger people tend to have that sciatic type problem, and that's related to a pinched nerve, which is associated commonly with a disc herniation. Disc herniations are fairly common things. My perspective is a little bit skewed because I see people who have the problem. I don't see people who don't have the problem. So, but keeping that in mind, I break down the category. In older people, they tend to have more arthritis problems, which typically is not a problem of younger people. But we still have to match the symptoms and the patient to what we're treating and make sure it's the proper match. It doesn't matter whether they have a problem at one level or two levels, because if the treatment gets them better, you're not going to treat it more aggressively anyway. When we're treating the spine through a surgical approach, the most important thing is to match the surgery to the particular problem that we're treating. And there are lots of different ways to approach these different problems. If we're treating a disc herniation problem, typically that's done through what we call a microlumbar discectomy. It's a small incision. Most of us use a microscope, a special high-powered microscope. We basically go down where the level is. We have to trim out a little bit of bone, move the nerve out of the way, and clean out the disc material that's pushing onto the nerve. You have to pick the right surgery for the right patient. Going from the back, nowadays we can sometimes put screws into the bone for what we call a fusion, and we can do it through small incisions. For most people, they should proceed with treatment of their spine at a pace that they're comfortable with. Personally, I don't think scare tactics, I don't think telling a person they might become paralyzed, unless it's the truth. I don't think saying that you should have something done because you might have a problem in the future, that for me just doesn't sit well. If we extend that logic, you should probably not cross the street because you might get hit by a car. And that's the same example I use in the office. And when people recognize it that way, then they'll say, well, I understand, that does make sense. As long as you're careful crossing the street, typically you're not going to have a problem. The same thing with your spine. If you have a condition, as long as you're careful about it, I don't think babying it, but as long as you're reasonable, then you can proceed at a pace that's right for you.